Hello friends, today we are going to discuss about acute kidney injury technical consideration for RRT. So first is anticoagulation. Hemofilter fibers are prone to thrombosis as removal of the fluid through ultrafiltration leads to hemoconcentration at distal end of the dialysis. As the filtration fraction, that is proportion of the plasma flow that is filtered increases, the risk of filter thrombosis also rise. The filtration fraction can be calculated as follow. Filtration fraction is equal to ultrafiltration upon plasma rate, and the alternative method is ultrafiltration rate upon plasma flow rate 100 minus hemoconcentration. Thus, higher rate of ultrafiltration, especially when coupled with low blood flow, predisposed to hemofilter thrombosis. So the poor filter performance and the filter clotting increases sharply at filtration when filtration fraction is greater than 20%. So higher blood flow rate permits the greater rate of the fluid removal since hemoconcentration within filter is limited by short transit time of the blood through dialysis cartridge. So IHD can be generally performed without anticoagulation. The higher blood flow used with this technique permits adequate solute clearance and ultrafiltration with limited risk of the dialyzer thrombosis. However, IHD without anticoagulation also necessitate the frequent saline flushes to hemodialyzer to help maintain fiber patency and therefore is more labor intensive than standard IHD. In addition, the pack grade blood cell transfusion cannot be infused through arterial line of dialyzer circuit because the resulting increase of hematocrit will lead to filter clotting. However, with CRRT, blood flow rates are typically low and ultrafiltration rates are high, especially for CVVs. And filter thrombosis is a significant barrier to effective implementation of this therapy, while also increasing nursing and the equipment utilization and need for the blood transfusion. Of note, critically ill patients with the COVID-19 infection undergo RRT have not been found to suffer filter clotting at particularly high rate. One approach for mitigating circuit thrombosis risk, called pre-dilutional hemofiltration, involves infusion of RF into CRRT circuit at point before the filter, thus lowering hematocrit through dilution. As a result, higher ultrafiltration rate may be achieved without compromising filter life. However, pre-filter renal filtrate also dilute the solute concentration of blood entering the filter, reducing the effective clearance. With this approach, the target effluent volume should be increased by 25% to compensate for dilutional effect. Other CRRT parameters such as blood and the ultrafiltration rate must be adjusted to compensate for this inefficiency. Anticoagulation is often necessary to maintain the hemofilter patency with CRRT, especially for principally convective modalities such as CVVH. When heparin is used for anticoagulation, an initial bolus of 1000 to 2000 unit is typically followed by continuous infusion of approximately 10 unit per kg per hour adjusted to maintain the partial thromboplastin time in venous line of blood circuit at 1.5 to 2 times control. The heparin infusion do result in some systemic anticoagulation and may be contraindicated for patients with active hemorrhage and heparin-induced thrombocytopenia. Despite theoretical advantages, low molecular weight heparin do not appear to offer any significant efficacy or safety advantages over unfractionated heparin for RRT. In addition, these agents are most costly and their anticoagulant effects are difficult to monitor. For patients with active hemorrhages or high risk of bleeding, Regional citrate anticoagulation is limited to CRRT blood circuit, offers several advantages, and is recommended anticoagulant for CRRT for patient without contraindication to citrate according to 2012 KDIGO-AKI guidelines. Citrate infused in the arterial limb of the CRRT circuit prevents the hemofilter thrombosis by chelating calcium, a critical component of a clotting cascade. Calcium chloride or calcium gluconate infused into the venous line of system restores the normal systemic calcium level. This approach appears to reduce the risk of hemorrhage and extend hemofilter patency. In addition, citrate can be used for patients with heparin-induced thrombocytopenia. Serum and ionized calcium level must be carefully monitored when using citrate, especially for patients with the significant liver dysfunction and calcium infusion appropriately adjusted. Citrate is hepatically metabolized into bicarbonate and can cause metabolic alkalosis. In setting of hepatic failure, citrate accumulation results in elevated total serum calcium but low ionized calcium levels, reflecting increased circulating calcium bound to citrate. Trisodium citrate solution, typically used in this form of anticoagulation, may also cause hypernatremia. Other methods of regional anticoagulation, such as prostacyclin infusion or heparin reversal with the protamine, have been less successful. Prostacyclin, an arachidonic acid metabolite, has half-life of only 3 to 5 minutes and inhibits platelet aggregation. However, it induces vasodilatation and is associated with hypotension, and it is costly. Protamine binds and neutralizes heparin, but infusions are technically complex and may be associated with rebound bleeding. Anticoagulation is unnecessarily for peritoneal dialysis. However, intraperitoneal fibrin can occlude the dialysis catheter. If fibrin clots are noted in dialysis, heparin, that 1000 units, should be added to each PD exchange for several days. Intraperitoneal heparin is not absorbed and will not cause systemic anticoagulation. Now, the blood and dialysate fluid. Maximum urea clearance with standard dialyzer required the blood flow of approximately 400 ml per minute. However, when dialysis is initiated for end-stage renal disease, the blood flow rate begin at 200 to 250 ml per minute and is increased incrementally over several sessions. The low blood flow limits the efficiency of dialysis and prevents the rapid solute and water shift that can precipitate complications including delirium, seizure, and dyspnea, collectively known as disequilibrium syndrome. With AKI, high blood flow rate may be used immediately unless blood urea nitrogen has been markedly elevated for prolonged. Blood flow rate for CRRT can vary from 100 to 400 ml per minute, but disequilibrium is not concerned because solute and fluid removal occurs slowly compared to IHT. The dialysate flow rate typically ranges between 500 to 800 ml per minute in IHT. These rates are sufficiently high so that changes of dialysate flow have relatively little impact on IHT clearance. However, because the dialysate flow rates are much lower in CRRT, increase of dialysate flow can significantly enhance solute removal. Now, the dialysis membrane. Most hemofilter are cylinder containing hollow fibers composed of semi-permeable membrane with varying surface areas and pore sizes. Pore diameters are sufficiently small to preclude movement of cellular material or albumin while allowing movement of smaller and middle-sized molecules. The surface area of the membrane depends on the number and length of this fiber. In case of patient with ingestion of dialysable substances, the use of hemofilter with large surface area will enhance the clearance. The initial hemofilter membrane composed of cellulose have been replaced by synthetic and more biocompatible membrane, which causes less complement activation and leukocyte adherence. Dialysate composition. The production of the dialysate begins with obtaining ultra-pure water, which is necessarily given the potential for backflow of endotoxin and bacteria to the patient. The standard composition of dialysate for both IHT and peritoneal dialysis is summarized into the next slide. The dialysate formulation for hemodialysis and peritoneal dialysis. For IHT, sodium is approximately 138 to 145, potassium 1 to 4, chloride 100 to 110, bicarb 35 to 45, calcium 1 to 3.5, magnesium 1.5, glucose 0 to 200. For peritoneal dialysis, sodium is approximately 132, potassium 0, chloride 96, lactate 35, calcium 2.5 to 3.5, magnesium 0.5 to 1.5, and dextrose in the concentration of 1.5%, 2.5%, or 4.25%. For IHD, chloride, glucose, magnesium concentration are generally fixed, whereas sodium, potassium, calcium, bicarbonate compositions are customizable. Sodium modeling, a strategy employed to prevent hypotension, consists of higher sodium concentration at the start of dialysis, followed by gradual reduction to prevent hypernatremia. The higher sodium concentration helps to prevent rapid fluid shift when urea is being rapidly cleared. The dialysate potassium concentration generally ranges from 1 to 4, with one dialysate generally reserved for cases of severe hyperkalemia. Use of 1 milliequivalent per liter dialysate is limited by its potential to cause arrhythmia due to rapid potassium clearance. The buffer used in dialysate is now uniformly bicarbonate. The concentration of bicarbonate in dialysate usually varies from 33 to 34. Higher bicarbonate concentration are used for severe acidosis or to offset the elevation of carbon dioxide resulting from permissive hypercapnia that attends the lower tidal volume ventilation. Dialysate calcium concentration during maintenance hemodialysis is 2.5 milliequivalent per liter of diffusible calcium. Because hypokalemia is common during AKM, the correction of acidosis further depress ionized calcium. Some experts advocate the higher dialysate calcium concentration, that is 3 to 3.5 milliequivalent per liter for patient with AKM. High calcium dialysate may be used to correct hypocalcemia, but should be used with the caution. Animal models suggest the calcium loading worsen the organ dysfunction and mortality for sepsis. For CRRT, wide variety of dialysate and the renal filtrate may be used. The composition of dialysate employed during the CVVHD may be identical to that of RF employed during CVVH. Potassium and calcium concentration are selected to meet patient's need. Base composition may be bicarbonate, lactate, or citrate. The later two buffers are metabolized to bicarbonate and effectively address acidosis for most patients with adequate hepatic function. The composition for peritoneal dialysis is relatively constant. These commercially produced solutions are available in 2 and 5 liter bags and are vary only in dextrose content. 1.5%, 2.5%, and 4.25% concentration. Icodextrin, a glucose polymer which is absorbed more slowly than dextrose, has been used for selected patients with severe hyperglycemia and poor ultrafiltration. If necessary, potassium, insulin, heparin, and certain antibiotic can be added to dialysis. Now, the next is dialysis access. Establishing and maintaining adequate access are paramount during the delivery of all type of the RT. Access is best considered into the two distinct settings. The end-stage renal disease patient with permanent access and AKI patient requiring temporary access. Now, AV fistula and graft for end-stage renal disease maintained with the IHD, permanent dialysis access include arteriovenous fistula and arteriovenous graft or tunnel central venous catheter. It is created by connecting artery to vein, and AV fistula must be matured, a process during which high blood flow causes gradual dilatation, thickening, or arterialization of vein proximal to the AV anastomosis. Once mature, AV fistula can be repeatedly cannulated several times a week for IHD. Considered the optimum access for IHD, the AV fistula provides blood flow, high blood flow, that is more than 500 ml per minute, relatively low thrombosis rate, and the low infection rate. However, AV fistulas requires a long maturation time, making them unsuitable for patients with the acute. In addition, AV fistulas cannot withstand continuous cannulation, precluding their use for CRR. For an AV graft, synthetic material is used to connect the artery and vein. Uh, like AV fistula, AV graft cannot be used to manage AKI as they require several weeks to mature and they cannot be used for CRR. Compared with AV fistula, AV graft are not durable and have high rates of thrombosis and infection. To preserve the patency of AV fistula AV graft, measurement of blood pressure, venipuncture, and constricting dressing or tourniquet should be avoided for access extremity. Acute thrombosis may also occur in setting of hypotension, severe volume depletion. Two conditions are common among the critically ill patients. Now, the peritoneal dialysis catheter. Unlike IST and CRRT, patients on peritoneal dialysis do not require vascular access. Instead, the peritoneal dialysis catheter allows for infusion and drainage of the dialysate from the peritoneal cavity. Most are made up of silicone and two synthetic cuffs, one placed beneath the skin and one beneath the abdominal fascia, which prevents the displacement in the infection of the catheter. Use of the peritoneal catheter is delayed for 1 to 2 weeks after placement to permit healing of insertion site and catheter tunnel. For urgent situation, early use of permanent catheter can be attempted with low volume exchanges in supine position, though this may increase the risk of dialysis leak or infection. Although very rarely used when access is required for AKI, the non-cuff peritoneal dialysis catheter can be placed at bedside and used immediately. This procedure should be reserved for unique situation and be performed by skilled operator because of the risk of bowel perforation or organ puncture. Now the hemodialysis catheter and insertion technique. For most patients with the AKI, dialysis access is achieved by placement of temporary central venous catheter. These devices fall into two different categories, acute non-cuff and non-tunnel lines or long-term cuff and tunnel catheter. All are large diameter and of dual lumen design. For patients with the urgent and the emergent need for dialysis, acute catheter provides rapid access for IHT and CRRT and typically inserted at bedside into internal jugular or femoral vein. Complications of this catheter include infection, thrombosis, vascular perforations. Cuff tunnel catheter are placed when the expected duration of dialytic support exceeds 2 weeks. Composed of soft materials such as silicone, they are usually inserted under fluoroscopic guidance into internal jugular or femoral vein and exit through subcutaneous tunnel. These dual lumen devices are available in different configurations. For appropriate function, catheter are placed so that tip extend to the right atrium, thus permitting high blood flow. Unlike stiffer acute non-cuff dialysis lines, the softer cuffed catheter do not pose the significant risk of perforation. The subcutaneous cuff and the insertion tunnel serve to anchor catheter and inhibit infection such that these lines may remain in place for several months or longer. Now, temporary hemodialysis catheter placement. The site of vascular access required for hemodialysis depend upon the status of the patient's peripheral vein and the urgency and availability of the team with the ability to place tunnel catheter. Critical care professionals often place temporary hemodialysis catheter when urgent hemodialysis is required or or when infection is contraindication to long-term hemodialysis catheter placement. When temporary hemodialysis catheter placement is indicated, the best available internal jugular vein is preferred site. When internal jugular venous placement is not possible, placement in one of the femoral vein is accepted. We advise against the placement of temporary hemodialysis catheter in either subclavian vein. Standard pre-insertion procedure include obtaining consent, procuring the appropriate supplies, preparing a sterile field for catheter insertion, and performing insertion team timeout that includes the two-item patient identification, procedure and site verification, review of allergy and hemostatic diagnostic, confirming the availability of functional monitoring and resuscitation equipment, and imaging assessment of vascular anatomy and patency. Bedside imaging study of choice is ultrasound evaluation of insertion site before and during insertion procedure. Method for organizing equipment required during temporary hemodialysis catheter placement, preparing sterile field, imaging the internal jugular vessel using point of care ultrasound, gaining vascular access, and wearing intraluminal guide wire placement. Thank you.